Hello, everyone. Thank you for joining us for the Provider Network training for our fourth quarter for CCHP. We'll get started in just a little bit. Thank you, everyone, for joining us. We're going to begin in just a little bit for this Provider Network training for our quarter four for CCHP. Thank you so much.
Good afternoon. Welcome to Contra Costa Health Plan Provider Network training for quarter four, or quarter three, I guess we're in. And we have a lot of presentations to cover today, especially regarding our DSNP launch of our dual plan, Contra Costa Healthcare Plus. We'll be going over the model of care today, which we will require that all of our contracted providers complete. So today we'll be able to complete that for those who attend, and you can attest that you have done it at the completion of today's presentation. And then additionally, we'll be going over some updates regarding the impact of the federal budget and the state actions, state budget, as well as the state actions, and to keep everybody apprised of that, and reviewing our transportation benefit, our CalAIM program, as well as the launch of our transitional rent, which is starting at the same time as our DSNP program, which is January 1st, 2026. And I think we can go ahead. Let me see how many people we've got. we're 3 minutes past the hour. I think I guess before we get fully started, let's give it just a couple more minutes and see if we have any other people joining us before we start the model of care presentation.
So Dr. Levin, we had a total of 48 to register for this, just as an FYI.
Okay. Yeah, so let's give people, it's right at the lunch hour. People are probably finishing up clinics, so we'll give it a few more minutes. Start. Thanks all my CCHP colleagues though for being on time. All right, I think we should go ahead and get started and let people join as they want. So again, good afternoon. Thank you for making it to the Contra Costa Health Plan Provider Network training. We have quite a few presentations for you today, including our model of care, which we need all of our providers to complete for our launch of our Contra Costa Healthcare Plus, our dual DSNP line of business that we are actively enrolling people in. So without further ado, I will, and please, everyone, as you join, if you want to use the chat and ask questions, please put them there. And we'll go ahead and get started. I'll turn it over to my colleagues, Beth Hernandez, the director of our quality department, and Laisel Avicilla, our director of case management.
Thank you so much. We're going to be going over our DSNP, which is our dual eligible special needs, our new Medicare Medi-Cal plan, a model of care training, which is going to be required for all providers that are participating in the DSNP program. If you want to go to the next slide. Oh, sorry, can you go forward? Thanks. So the model of care is a requirement from CMS, and it's a testament to look at how it's a a product that all health plans with the DSNP carry, which is looking at how we are supposed to be providing care to our dual eligible members. And it's a basic training, and they want all providers, CMS, to complete this training on either an annual basis or when our model of care changes. So as we are going through this, we're going to be covering a few different topics, just some very basics about what is a DSNP, some information about who our population is. The vast majority of the presentation is going to be really focused on our care coordination services and provider network, and then just a little bit of information on how we'll be looking at quality. So we're going to go to the next slide. So a dual special needs plan, what is a dual special needs plan? This is a type of Medicare Advantage plan where individuals can enroll. They have to actively enroll, and it combines their Medicare and Medi-Cal benefits into one plan. So there are many types of special needs plans. There's a C-SNP for individuals with chronic conditions, ones for individuals who are institutionalized, and the one we are participating in is called a dual eligible special needs plan, which is specifically designed for people with Medicare and Medi-Cal. And the name of our plan is going to be Contra Costa Healthcare Plus. If you go to the next slide. So what it does is it basically combines that Medicare and Medi-Cal into one plan. So people will have one ID card and one phone number to call. I think what's important to note is that individuals can receive some additional benefits that are not available in fee-for-service Medi-Cal. So we offer some supplemental benefits. However, it does mean that individuals have to operate within a managed care plan framework. So that means that they would be limited by the DSNP provider network that we have, and also prior authorization rules. So it doesn't replace Medicare or any other Medicare options. People have to select the plan specifically, and no one is auto-enrolled in the plan. Next slide. So essentially, like I mentioned, it's taking an individual's Medicare Part A and B benefits. It combines their Part D benefits with that. So we'll have a pharmacy component of our plan. It combines their Medi-Cal benefits and then their supplemental benefits as well. Next slide. So to be eligible for this, an individual essentially has to meet both the Medicare and Medi-Cal eligibility requirements. So someone needs to be enrolled in Medicare, so that means over 65 or qualifying for a qualifying disability with Medicare. And they have to be receiving Medicaid or Medi-Cal within Contra Costa County. So you go to the next slide. Children under the age of 21 are not eligible for this plan, even if they have Medicare. It's specifically designed for those older than 21. So again, people have to be enrolled in Medicare. They have to be receiving full scope Medi-Cal. So share of cost Medi-Cal is not a qualifying coverage for the plan, and they have to be within our service area. And so how people will enroll is they can begin enrolling actually right now through our enrollment line or on Medicare.gov. This is called the annual enrollment period for Medicare, which I'm sure you've seen many ads on in the newspaper and on TV. So individuals can enroll right now in our plan, but because they're a special needs population, they're also allowed to change at any time during the year. So that means starting in January, they can enroll any time during the year, and their coverage will be effective the following month. It also means they can go back to regular fee-for-service Medi-Cal and Medicare separately. So a little bit of information is there's about 34,000 dual eligibles within Contra Costa County. We currently provide the Medi-Cal arm for about 24,000 of those, and Kaiser has the rest of the members. Next slide. So what is the benefit of being in a dual eligible special needs plan? I think some benefits to members, which you're going to hear about, some of the care coordination services that are extremely going to be helpful for members. I'd say their Medicare and Medi-Cal is coordinated along with their prescription coverage. So it's all under one plan umbrella. So not dealing with different insurance companies or a different Part D provider. They're also going to have a single ID card and a single point of contact. And then we also have some supplemental benefits like expanded vision and an OTC flex card for individuals. Some of the benefits for the providers, I think, is all of your patients are going to be eligible to receive some additional care management or care coordination services. All of information around authorizations is going to be coordinated under one plan, and a single payment of claims, so no crossover billing would be needed for these services. Next slide. So what is the model of care? It's a foundational framework that how we as Contra Costa Health Plan are going to be delivering these services. So this is a requirement that CMS has, that we write a document on our model of care. So you're going to see a very shortened version of this as we go through. So it's really our detailed written commitment about how we're going to be providing services for dual eligible members. Next slide. So essentially, as we think about our model of care, we really want to make sure that the patient is really at the focus of everything. I think we have a few different focuses in the model of care of focusing on prevention. So making sure individuals receive routine visits, they have personal care plans. We're focusing on outcomes. So we're looking at some quality measures like improved A1C blood values, looking at controlling blood pressure, and then focusing on quality. So we're really looking at some clear quality reporting measures and promoting a vision for improved care. Next slide. So the model of care has 4 different elements. The first one is basically describing who our D-SNP population is. The second one is going real in depth around care coordination. The third is around provider network. And then the fourth one is on quality. If you go to the next slide. So I'm going to get into a little bit on our D-SNP population, who our patients are, before I hand it over to Liesl to talk about care coordination. If you go to the next slide. So our D-SNP population is largely seniors. So over 80% of our population are over the age of 60, with that 60 to 69-year-old group making 32%. About 1/3 of our individuals receive Medicare due to a disability, while about 2/3 receive Medicare due to age. We're predominantly more female than male. It's a very diverse language diversity of our membership, just like our Medi-Cal population, with about 30% speaking a language other than English. Again, very diverse population of our membership. And about 10% of the population has either experiencing homeless or is at risk for experiencing homelessness in our membership. So I think this really is speaking to the costs of living for older adults, that this is such a high rate. Next slide. In addition to looking at our overall population, our model of care also has us look into identify a group that we will call a vulnerable population. So how are we risk tiering our population to those with the highest needs and then delivering tailored services? So part of that was us defining who is considered vulnerable in our population. And so we have a long list of indicators here. These largely align with a lot of our other case management programs. So looking at people who have frequent inpatient admissions, polypharmacy, individuals with homelessness. So really looking at some of our most high need patients. Next slide. And so when we compare our populations, our general D-SNP population, to those who are most vulnerable, you're going to see in the graph, the orange is the most vulnerable population. You can see it skews a little on the older side with the most vulnerable. The homelessness rate is much higher with our most vulnerable population, 4 times more likely to be homeless.
Did you eat your soup?
Similar in race.
You're not eating? Were you waiting for Sissy? Okay, sit down so we can eat our soup together.
Okay.
Elise, could you mute?
I think she just got it. Next slide. Oh, Erin, can you just go forward one? Thanks. Okay, and now I'm going to hand it off to Liesl to talk through care coordination.
Hi, good afternoon, everyone. I am Liesl Avicilia, the Director of Case Management here at Contra Costa Health Plan. A lot has already been covered by Beth in the previous slides, and as she mentioned, I will be focusing more on the model of care 2, which is care coordination. This section of the model of care provides an overview of the roles of the D-SNP care coordination team. This also includes how we conduct our HRAs, how we create our care plans, and form our interdisciplinary care teams for the members. It's important to note that every D-SNP member will have an assigned case manager, making it easier for the member and also for the providers in navigating care. First off, we're going to go ahead and start with the health risk assessment. Next slide, please. All right. For us to get a full picture of each member's needs, we do use a comprehensive health risk assessment. You'll often hear this as termed HRA. This helps us look at everything from medical and functional needs to cognitive, behavioral health, and psychosocial concerns. Members can complete this HRA in whatever way works for them. This can be by mail, over the phone, or they can also complete this through online through MyChart. We do initiate the first HRA within 90 days of when the member enrolls, and then we can go ahead and check in again at least every year after that. And if there's any big change in their condition, like hospitalization, we'll go ahead and do another one sooner. Once we have all of that information, we then use that to build an individualized care plan, or ICP for short, within 30 days of the HRA assessment. This care plan helps us guide how we support each member and make sure that the care team is also aligned around the member's specific needs and goals. Next slide, please. All right. The ICP is a comprehensive person-centered plan that's all about the member. This, as I said, outlines their specific problems, goals, and interventions that we'll use to help meet the members' unique needs. We create this ICP using a variety of data sources, starting from the health risk assessment, but we can also go ahead and pull in information from utilization history, claims, pharmacy, and any other clinical records that may be available for us. And this approach then gives us a well-rounded view of the member's health and social needs surrounding it. The care plan also addresses how we'll coordinate care across the board with the providers, community agencies, external partners, and any other Medi-Cal carved out benefits that the member may be receiving. The interdisciplinary care team takes the lead in developing this care plan, working obviously closely with the member and their caregiver to make sure that the care plan is accurate and reflects their preferences, priorities, and circumstances. We do update this ICP at least once a year, or again, if there's any significant change in the member's health or life situation. And once this is complete, we make sure that this is shared with the all of the members of the ICT, the member, and any other appropriate stakeholders involved in the member's care. Now we're going to go ahead and move on to the ICT. Next slide, please. Oh, sorry. Slide before that. Oh. Slide. Oh. Or, yep. Another one forward. Sorry, there might be a delay in the. Another forward. All right, perfect, thank you. The ICT is put together based on the member's health risk assessment, their identified needs, and any other preferences. The primary care provider plays a very important role in coordinating care and supporting any transitions that the member may experience. Core ICT typically includes the primary care provider, the DSNP care manager, a pharmacist if needed, a social worker if needed, and something that's called California Integrated Care Management, with CICM for short, if the member is eligible for it. And of course, the most important one is the member and or the caregiver. We can also go ahead and add other team members that might be needed to meet the member's needs. For example, if this patient is eligible and or receiving palliative care, any long-term services and support providers such as IHSS, community-based adult service, or any facility-based staff. The team works together to make sure that the member's care is, again, coordinated, person-centered, and responsive to the changes in the member's condition or goals. Next slide, please. All right, so Now that we've covered the ICB, the ICD, we're going to go in and take a look at the tool set is available for the providers as well as the members in making sure this care coordination happens and everyone is on the same page. There are two key tools we use. On the left side, you'll see the provider portal. On the right side, you will see the member portal, also known as MyChart. The provider portal is designed for our clinical partners. This is how we share the members' profile with the provider and their and any other members of the ICT. Within this portal, providers can view important information such as the HRA, the ICB, who's the members of the care team, member health records, gaps in care, medications filled, claims data, and lab results. On the other side, we do have the member portal, also called MyChart. This is the main communication between the members and us as the care managers, also the PCPs. This gives them access to their full profile and helps them stay engaged in their care. Same as the provider portal, the members can then view their HRA results on MyChart, their ICP and ICD, any authorization letters that they have, member services and treatment history and claims history, and their current medication list. Both of these portals make sure that the providers and the members have the information they need to make sure that they're staying informed and aligned with the members' care plan. Next slide, please. All right, so now we're going to move on to the annual face-to-face encounter. Members must have a face-to-face encounter within 12 months of enrollment and then at least once a year after that. The goal of this visit is to make sure that we check in on the members' overall health, deliver preventative care, and review or update any goals that's outlined in the individualized care plan. This encounter must take place between the member and a participant of the ICT. Most often, this is the primary care provider during an annual wellness visit. This can be done in person or via telehealth using a real-time video platform. During these visits, clinical activities may take place, including engaging with the member, coordinating care and supporting case management, conducting or updating the health risk assessment, delivering prevention and wellness services, and providing support for transitional care, especially after a hospitalization or major life change. These encounters are very important in keeping, again, I think this is a broken record already, keeping the members' care member-centered, proactive, and aligned to the members' needs throughout the year. Next slide, please. Beth, did you want me to cover provider network? Sorry, was that a yes?
Yes, if you can, yeah.
Okay. All right. So the provider network section of the model of care gives an overview of our DSNP provider network, how we conduct our provider training, how clinical practice guidelines and care transition protocols are observed and practiced. Our network includes PCPs, specialists, behavioral health providers, long-term support and services providers, palliative care providers, and any other community-based organizations out there. Providers do undergo credentialing every 3 years and goes through ongoing monitoring through our provider network team. We do have a centralized provider database that feeds into our provider directory online. Next slide, please. All right, now let's talk about how we can work together and what are the provider responsibilities under our DSNP line of business. Providers do play a very important role, as we were already mentioned earlier, in bringing the care plans to life. We're going to go ahead and start off with communication. This means staying connected with the case managers, ICT participants, and members or caregivers to discuss the care plan, treatment, and any educational needs that the member may need. Providers also do facilitate meaningful interactions with the members, whether that's through face-to-face or through telehealth, helping create a personalized and supportive approach to care. We also, the providers are also expected to work closely with the Contra Costa Health Care Plus case managers to develop and maintain each member's ICP, to make keeping it updated in the member's medical record. Providers are also to review and respond to any important updates in the provider portal or in Epic if you're an internal provider, and to actively participate in ICT meetings, sharing input that helps us guide the members' care. And another important role is educating the members on the importance of completing their health risk assessment, because this is, as mentioned earlier, this directly shapes their care plan. We also encourage our providers to encourage our members to stay connected with their care manager for continued support and coordination. And finally, completing this model of care, as Beth mentioned, is required for DSNP providers to complete this model of care training, both at onboarding and recredentialing, to make sure that we're aligned with the Care Plus, Contra Costa Health Care Plus standards and best practices. All in all of these responsibilities hopefully will help strengthen collaboration, improve member outcomes, and to make sure that all these SNP members receives coordinated and, again, personalized care. Next slide, please. I think that's it for me. I'll go ahead and pass it on to Beth. Oh, sorry. I can go over this, Beth, if you're. Yeah, okay. All right. Sorry. One last slide. This slide covers how we here in Contra Costa Care Plus, we do rely on evidence-based clinical practice guidelines to promote high quality care and to make sure that we do have optimal outcomes for our DSNP members. These guidelines help providers make informed decisions that align with the best possible clinical research and national standards of care. Our guidelines focus on conditions that are most common with our dual special needs population, including behavioral health conditions, diabetes, COPD, CHF, hypertension, asthma, and obesity. And to make sure all of these guidelines are not just available, but also being used effectively, we here in Contra Costa Health Plan, we make sure that we monitor and we reinforce the application through multiple quality oversight activities, including facility site reviews, medical record reviews, member grievance findings, pharmacy findings, utilization management findings, as well as case management findings. And I think that's it for me. Thank you very much. I'll hand it off to Beth.
Erin, okay, on to quality measurement. If you go to the next slide, please. So as part of our model of care, we also prepared a quality measurement and improvement plan. And so this is part of our normal quality measurement cycle, and where we prepare an annual plan and then do some annual evaluation and continuous improvement on our quality. If you go to the next slide. So we have a number of different quality goals and health outcome goals. These are largely many of the same items that we look at for our Medi-Cal population, but some new ones for DSNP, which includes, we'll be looking at the percent of members who have their health risk assessment completed, like Liesl just spoke about, people who are engaging with their interdisciplinary care plan and are part of a care team, looking at some measures around timely access, and then also some quality measures like breast cancer screening, colorectal cancer screening, some diabetes quality measures, and hypertension quality measures. If you go to the next slide. We'll also be doing measuring of satisfaction in the program. So we do a couple different surveys as part of our DSNP. The first one is called our CAP survey, which is a standard survey that goes out to a select number of individuals to see people's experience in the health plan. And then the second survey is called the Health Outcome Survey, which is a cohort-based survey where the same individuals are surveyed year over year for 3 different years, where they compare people's health outcomes to the baseline survey. So asking a lot of questions around IEDLs, ADLs, etc. If you go to the next slide. And that is the completion of our model of care training. So thank you so much for completing it. There is an attestation that for us to kind of credit you all for completing this. So thank you very much. I'm going to put it in the chat too, so it's easier to click through. So that is all I had for model of care. I think we can go to the next slide because we have a few other topics to cover today.
Thank you, Beth and Laisel.
And I think I am back up.
You're back up.
Okay, thank you. Okay, so if you go to the next slide, I'm going to talk a little bit about some HR1 updates and state budget cut updates. I know there's a lot of concerns around some of the rollbacks that will be happening both at the federal level and at the state level. So I'm going to review a couple of the key provisions, but I think probably, which I'm sure many of you have heard about, but also go into some of the timelines, because I think that will hopefully be helpful to kind of ground you in when various things are going to be getting put in place. So some of the major Medicaid provisions from HR1 are really kind of bucketed into these 4 areas. The first is eligibility and access. Work requirements are going to be required for a certain proportion of the Medicaid population around the country. Additionally, there are going to be 6-month eligibility checks for redetermination for certain groups of the population. Right now, people typically go through redetermination annually. This is going to be tightened up to 6 months, which will result in more individuals losing their Medicaid coverage. Some of the other changes relate to retroactive coverage. So right now, if somebody doesn't turn in their paperwork, they turn it in late and their Medi-Cal lapses, they have 3 months with which to turn in their paperwork and their coverage is restored. That's going to actually be shortened up to a 1-month retroactive coverage period for all aid codes except for children, which will be 2 months. So this is going to have much more difficult with people than having to complete a full Medi-Cal application to get back on coverage. And then there are also some proposals to be adding some premiums into Medicaid, and that's going much further down the road on the roadmap, but that is also something that was part of HR1. I think the second bucket really is around state financing, that there are some major changes of how dollars flow from the federal government to the state government and how that payment is, how much of that payment is. So some of things that are being restricted is something called the managed care organization or provider tax. So this is a financing mechanism where dollars that are spent through either providers or through managed care organizations are then getting matched by the federal government. Some state directed payments, which are going to largely public hospitals, are getting rolled back. And then there's going to be repayment penalties if there are improper payments for ineligible Medicaid recipients. I think the big thing about this bucket is that this is basically a large funding constriction that then is going to likely, states are going to need to decide on their own how they are going to handle the reduced funding in Medicaid, which may be related to further cuts down the road in terms of eligibility or benefit packages. So as people are assessing their state budgets. Third bucket is around immigration coverage limitations. Currently, states are receiving, there's a reduction in the matching rate for emergency Medicaid for individuals without documentation. And there's also going to be restrictions for individuals who may be on refugee status, who are currently eligible for Medicaid nationally, but will no longer be Medicaid eligible. The fourth bucket is around banning abortion providers and entities that are providing services. So this is around Medicaid funding cannot be going to certain entities like Planned Parenthood, even if those services are not for abortion services. Go to the next slide. So this is just a timeline going through all of those items that I just went through, so you can see when various things are going into effect. So the first things that we're really going to see at the federal budget cuts are really going into effect, really focusing on in Q1 2027, when those work requirements and the eligibility cuts and the shortened Medicaid coverages will be enacted. Some of the rolling back of funding is really starting now, as states will be getting less funding going forward, which may then cascade into further cuts. The co-payments won't be going into effect for the Medicaid population until Q4 2028, if that proposal stays around that long, or if that part of the law doesn't get repealed. Next slide. So in addition to the cuts at the federal level, there were also some major cuts to the Medi-Cal program within California as part of the last year's budget. So the state had a very large budget deficit that had to go into rainy day funds. And a lot of the budget deficit was attributed to spending in the Medi-Cal program, or increased spending in the Medi-Cal program. And so to address some of the budget shortfalls, the state enacted some major cuts to Medi-Cal. So the first of these is freezing enrollment for those individuals with unsatisfactory immigration status, for who is 19 years old and over, and that begins on January 1st. People who are currently enrolled will get to retain their Medi-Cal coverage, but no new individuals will be enrolled with unsatisfactory immigration status. The state will also be creating premiums for these individuals starting July 1st, 2027. So individuals would need to pay a monthly premium to retain their Medi-Cal services. There are also going to be reduced funding for federally qualified health centers that for their visits their visits for individuals with the UIS population. So people will still get paid for the regular Medi-Cal rate, but there will be no PPS wraparound funding for the UIS population. There will also be a reinstatement of the assets test for individuals, seniors, and in persons with disabilities. This asset test was removed in, I believe, 2024, and it is getting reinstated at a higher level, but still individuals are going to need to prove their assets prior for redetermination. Dental benefits are getting eliminated for individuals with unsatisfactory immigration. Some dental supplemental payments are being reduced as well. And then there's some pharmacy changes that are going on as well for Medi-Cal RX. Some of these are elimination of GLP-1s for weight loss. There's also going to be elimination of certain over-the-counter drugs that are now covered under Medi-Cal RX. And they are implementing some prescription drug utilization management and step therapy as well. Those are all effective January 1st. I believe that's all I had, but just wanted to give a high-level overview of some of the state and federal implications and how that relates to all of your patients.
I think I have the next slide, which is just about AB 144. Some of you may have heard of it, Assembly Bill 144, and then the formation of the Western Alliance of States. here in the West, which happened in September, California, Oregon, Washington, and now Hawaii has joined, formed the Western State Alliance with the purpose of aligning around continued enactment and support of vaccines and preventive care provision, committing, and that's what AB 144, the legislation that it passed in California, which essentially sets January 1st, 2025, keeps those recommendations in place, as well as it requires health plans to cover preventive services and vaccinations per the January 1st, 2025 guidelines from the CDC. And so that is what the other states will pass similar legislation or have done so, but essentially all of our members will continue to have access and coverage for those vaccines that were recommended as of January 1st, 2025, as well as preventive care. So one light of hope, and hopefully we'll see more come out of the Alliance in this. I'm just gonna pause there. I know there's been a lot of information, and just see if there's any questions from any of our participants today.
I don't see any questions in the
Okay,
conversation either.
okay, let's move on then. All right, and we have Cynthia Laird to give us our transportation guru, to give us a presentation on services and changes.
Yes, good afternoon, everyone. Thank you, Sarah. I am the supervisor here for the transportation department, and I just wanted to go over a couple things that have changed in transportation. Next slide, please. All right, so we have now partnered with Roundtrip. So Roundtrip will now be managing our call center, and they will continue to book our NMT, which is non-medical transportation, and now they are booking our NEMT rides, which is the non-emergency medical transportation. So what does this mean for us now? It's 24/7, which means that you can call after 5 o'clock. So for any of those, if you have any staff that reaches out to members and speak with members directly, please inform the members that we are now available 24/7. And so I think that's great for the members. They don't have to call in that time frame from 8 to 5 anymore. We're available the weekends after 5. So please inform the members that they can now call after 5 o'clock. And when they're calling Roundtrip now, they are booking their transportation on the spot. So we still are requesting the 5 to 7 days. That's the policy. But once you get off the phone, your appointments are booked with Roundtrip. And you will get a confirmation with that, and I'll have the information later on the slide. I think this is going to be a great thing for us now, so in the near future, we're going to streamline the rides so you can book online. So the members will be able to book on their own, which will be coming. I wanted to inform you guys that I'm currently working on our case managers having access to be able to do will calls. And a will call is when the member is ready to go home from their appointment to home. So I'm working on that. So that's coming soon. So Lazel, look out for that. We want to make sure that our members are happy. That's our goal. Okay, next slide. So for non-medical transportation, the numbers have not changed. So please call the 855-222-1218 for rides. So for our NMT, which is for our Lyft, Uber, taxis, paratransit tickets, and for public transportation, they will still be, we call those part of our NMT. So for any escalations, questions that Round Trip has, we still have a team that's based here in Contra Costa Health Plan that can still help members when needed. So if there's any escalations, like there's no authorization on file, a non-contracted provider, or out-of-county dental, or need paratransit tickets, the calls will be transferred from Round Trip to our Contra Costa Health Plan team here. So the members will be helped no matter what. If Round Trip does not have the answer, they would transfer the call here to Contra Costa Health Plan. Okay, next slide. And for our non-emergency medical transportation, you can still call Round Trip for those rides. If there is no authorization on file, which I am super excited about this, the calls will be transferred to our Contra Costa Health Plan team, who will now work on all of the authorizations as far as getting the PCS form, I'm sorry. Journey Health will no longer participate with helping with transportation. So please do not reach out to Journey Health for any transportation needs. Round Trip will book the rides. If a PCS form needs to be completed along with a referral, Round Trip will reach out to Contra Costa Transportation team, and this team here will then contact the PCPs to get the PCS forms and referrals done. There is no work that anyone else will need to do. That will all be done in-house. After the prior authorizations have been approved, the department here, the Contra Costa Transportation team, will reach out to the member or the case manager, social workers, to notify them that it is ready to be booked. And we'll go ahead and we'll let them, we can actually book them here if they're ready, but a lot of times they're not ready, so they'll go ahead and call Round Trip to book those rides. And I think this is going to be great for all of us to be able to do this in-house now, to be able to get the PCS forms done in a timely manner, make sure they're done correctly. We can communicate with the authorization department. This is all coming together within CCHP transportation team. So I think that this is helping. And so I just wanted to let you guys know that now we're in-house with the NEMT for any PCS forms. Okay, next slide. I wanted to share with you the phone numbers just in case, because members may have questions about this. So for the initial booking, again, you'll call the 855-222-1218, and that is for NMT or NEMT. For will calls, for ride edits, cancellations, or just for general questions with Round Trip, you will call this 877-396-8080 number. Members will receive a text message or automatic phone call when their ride is being booked. So they get a confirmation, and these are the numbers that it come from. A lot of members may think that these are spam numbers, but they are actually Round Trip's phone number to inform the members that their ride has been booked. So these are the two numbers. If you guys have any questions here, you can always reach out to myself, and I'd be happy to help. Do I have any questions about the Round Trip or the transition? No. Okay, well, thank you all for having me. I truly appreciate it.
Thank you, Cynthia. And next we have Peja Gadsden, our Director of CalAIM Programs and Transitional Care Services, up to talk about CalAIM Transitional Rent. Thanks, Peja.
I think Peja might have disconnected real quick. Let me see if I can Teams her to get her back. In the meantime, I did want to point out too, we also have, in regards to the APLs, we did not get updates from the compliance department yet. So that should be sent over to Provider Network via the provider newsletter, which will be going out shortly. So we didn't get those updates in time.
All right, thank you, everyone. My name is Peja Gatson. I'm the Director of CalAIM Programs and Transitional Care Services, and I'm going to give a brief overview on CalAIM Transitional Rent, the newest community support that goes live on January 1st of 2026. Next slide, please. All right, so transitional rent, as we said, is a new Medi-Cal community support really designed to assist our members that are experiencing homelessness or at risk for experiencing homelessness for up to 6 months of rental assistance. Now, this can be either in an interim setting or a permanent housing setting. Ideally, this is going to be in a permanent housing setting because our goal is to keep people housed permanently. The first population of focus that we're going to be going live with when it comes with transitional rent are going to be our individuals that have behavioral health needs, okay? So really, again, the goal of the program is going to be to connect the members to long-term housing supports and really to promote that stability, to really use the temporary housing stability to really link our members to the rest of the needs they have, including healthcare, and also to really reduce any administrative burdens while really maintaining the program integrity. Okay, so we really want to make sure with the transitional rent, it's not just about taking somebody off the street and just putting them into internet housing. It's about really making like a long-term pathway for stable, permanent housing for our members. Okay. Now, you'll also hear, just like in enhanced care management and transitional rent, we have populations of focus. In the little picture at the bottom of the screen, you're going to go ahead and see really kind of the steps 1, 2, and 3 related to the eligibility for a transitional rent. So specifically for the first population of focus, again, that we're going live with on January 1st, it's focused on those that have behavioral health needs. So these are going to be individuals that are going to meet the access criteria for specialty mental health services through our county behavioral health services, drug Medi-Cal or drug Medi-Cal ODS. These are also individuals that need to be experiencing homelessness or at risk for homelessness, and they need to be transitioning from a specific transitioning population. So maybe these are individuals that are coming out of SLEs. Maybe this is an individual that's coming out of incarceration. They need to be transitioning from one of those specific populations to be eligible for this community support. Next slide, please. So again, a little bit on the different populations of focus. There are going to be a total of 7. Again, not to cause any confusion when we call, especially ECM populations of focus, but these are only specific to transitional rent. So as we talked about the first population of focus, you'll have in the tan there, kind of what is that clinical risk factor that a member must meet. Of course, we have that second qualifier, which is experiencing or at risk for homelessness. And then you'll see all the different places that an individual can be transitioning from. So congregate living, incarceration, an interim setting, one of our recuperative cares or short-term post-hospitalization housing. Maybe this is one of our TAYR transitional age youth that are transitioning out of foster care, and they need this assistance to go ahead and get on their feet, and those that are experiencing actually unsheltered homelessness. And all of this also is going to be covered in the Community Supports Policy Guide that was released by DHCS in April of 2025. Next slide, please. Okay. So one item that I know I hear a lot about, people ask me, what's going on with this global cap, or how do we make sure that they're going to stay really housed long term? What happens after we go ahead and utilize this 6 months of services? So with regards to the global cap, our federal government, at the end of last year, put a cap to the programs that provide some sort of room and board service. So those are going to be transitional rent, our medical respite or recuperative care that is ran out of Philip Dorn Respite, and also our short-term post-hospitalization housing that's also run out of Philip Dorn Respite. Okay, so now starting January 1st of this year, you cannot use any of those programs together for longer than 6 months. So even though they all have their own individual income limits, also as a collective, we cannot go over 6 months. So what that means is that while the transitional rent is a 6-month program, if you, let's say, have already been in medical respite for 3 months, you're only going to have 3 months of transitional rent. So it's not just going to be that clear cut that everybody gets 6 months. It's really going to depend on how much of that benefit they've used thus far, and we'll be tracking that. Okay. Also, really the reason why we're starting with the behavioral health population of focus is that there is special housing and waivers under the behavioral health really population of focus through our county behavioral health services that allow us really a much more streamlined process for these members to permanent housing. So it's really kind of working as a collaborative and a collective together to make sure the members are really kind of moving through the process to permanent housing and that we can keep them stably housed there. For this community support, this is going to be one of our community supports that we will be delegating. This will be delegated out to H3. They will be the ones that will be reviewing, monitoring, and actually providing transitional rent to our members starting January 1st of 2026. Next slide. And this is just kind of like a brief overview. I like pictures that shows kind of what it would a CCHP member's journey be. To the left, you kind of see the different programs from housing transition navigation, temporary housing assistance, ECM, housing deposits, and tenancy sustaining. Those are other community supports and resources, and you can kind of see how those really go around the member to support them, again, since the goal is going to be long-term, stable, and permanent housing. So a lot of coordination and collaboration between those programs and different departments within the county. And then also to the right, you'll go ahead and see what happens maybe for a member that's experiencing homelessness as they go from hospitalization to TCS, that is transitional care services. How that member may then from their hospitalization go into recuperative care, where we're going to be laying on enhanced care management to really wrap around them, as well as housing transition navigation, which is another one of our community supports, to really start looking for that long-term stable housing for that member. Throughout this whole entire continuum, you'll see where you get to housing deposits. That means that we've really identified that housing. We're going to use our community support housing deposits to go ahead and have that member placed into housing, where we see our little house in the middle. And then that's where transitional rent comes in. That's also where housing tenancy and sustaining services come in. Again, since the main goal of this program is long-term sustainable housing. And then you see obviously permanent housing subsidy, because again, we know that there needs to be some level of support really to go ahead and kind of take this over after that transitional rent benefit has exhausted itself. And that's why we're going ahead and really connecting with H3 and our other housing partners to make sure as we're moving members through this continuum and utilizing this community support, that they have a subsidy that's going to be ready to start day one of potentially month 7 or day 1 of month 3, whenever this is exhausted. Next slide. That may be my last one. So I don't know if we can open it to questions. Otherwise, that's everything I have for transitional rent. Thank you.
Thank you.
Next, we have Beth up again.
I'm back again. Okay, next slide. So we received back our 2024 HEDIS submissions, which we finalized in June of the year. And first, I just want to say a very, very big thank you to all CCHP providers. This was one of the best quality measures submissions that I've ever experienced in my 20 years of working. You can see the number of 90th percentile nationally, where the care that you give every day reached like the best in the entire country. These ranged like across a wide range of indicators. So things from prenatal and postpartum care to childhood immunizations to cervical cancer, chronic disease management. So a really wide array of measures reached this high level. So thank you so much for all the work you do every day. I know my team collaborates with a number of the different quality leaders on your teams to try to work on measures and do improvement projects. So thank you so much for all of the collaboration over the last year. If your practice is interested in any collaboration, I'll put my email in the chat, and please feel free to reach out and we can set up a meeting with our health ed team to think about anything that we can work on together. If you go to the next slide. And so I'd say once we added up all of our quality measures, we submit these to NCQA and they release a ranking of all of the health plans in the country. And we ranked 4.5 out of 5 stars, which is a very high rating. No Medicaid plans in the whole country received 5 stars, and we were only one of 14 in the country to have 4.5 stars. And when we compare to other California plans, the only other 2 plans with 4.5 stars was Kaiser Permanente Northern California and Kaiser Permanente Southern California. So I think that's pretty incredible for all of the work that you all do. So thank you so much. I also just put a link in there in the slide presentation. We were just recently featured in an NCQA article on their website about our provider network and the great quality that you all give. So thank you all to all the providers. That was all I had.
Great, thank you, Beth. So just a reminder that our CCHP linguistic services, interpreter services are available to all of our providers, contracted providers who are seeing our members. And we encourage you and require you to provide telephonic interpreter services when seeing patients who have or do not have primary English speaking. So we make it easy to get to Spanish, but there are, I think over 40 different languages available. And this is what's, required to provide in order to document those services. If there's ever any questions about how to access interpreter services, please do not hesitate to get in touch with us. We can provide you with the information. You do need a code, which is for the billing and the identification of us as the client, Contra Costa Health Plan. So the client ID, and then for mental health providers, it links to our mental health client ID number. And reason we did want to emphasize this on today's training is, this is something that we have gotten repeated grievances about from our members in terms of not having accessible interpreter services when they are seeing providers. So we do reach out on an individual basis when we get those grievances, but want to bring it to the attention of everyone today, the training. Thank you. Next slide. So there is in-person, face-to-face interpreter available as well. And those need to be scheduled 5 days in advance. Or you can call, or you can complete the request form with the links here. And these slides will be provided. And you can do for a telehealth appointment, we can also arrange for a virtual interpretation. Next slide. And additionally, if you need assistance with translating documents for CCHP, you can email our CCHP quality with the document in Word version, and please remove all personal health information if possible. And that will allow for shorter turnaround time, and always encrypt the email if the document does contain PHI, and never include PHI in the email title or in the file name. And again, if you have any questions regarding linguistic services, please email cchp.quality@cchealth.org. Next. Closing reminders. Good, we'll give everybody back some time today. Please remember to use the link to do the attestation of completing the model of care, so we can give you credit for that. And that, again, that link is in the chat, and it'll also be available in the slides, which will be available to you after the training today. And do any other reminders from the group or questions? All right, great. Well, have a great rest of your week, everybody, and enjoy 20 minutes back of your day today. Thank you.
Thank you.
Thank you.